Welcome to the Terminology Leading Practices stream of SNOMED Expo 2020. My name is Monica Harry and I am the Director of Content and Mapping at SNOMED International. I will be moderating today's session. Please use the question and answer box to type your questions to the presenter, and all questions will be answered at the conclusion of the presentation. I'm now pleased to introduce Carol Macumber, EVP Architecture, will be presenting along with colleague COVID Interoperability. I'll hand it to you.
Great, thanks, Monica. Sorry, I had to hit next. See that? All right. So welcome. Thank you for joining us. I'm just going to do a quick kind of introduction to the panel format. I'm joined here by some of my esteemed colleagues, and we're really excited to bring this topic to this SNOMED Expo. So we're going to go through the COVID-19 Interoperability Alliance, do some introductions and background, and do an overview of the collaborative approach and member implementations. We were going to do a moderated panel discussion, but since this is coming to you recorded, we're going to go ahead and skip that and go straight to attendee discussions and live Q&A after the recording. So with no further ado, my name is Carol Macumber, as Monica has introduced. I'm joined here today by Dr. Victor Lee, our VP of Clinical Informatics at Clinical Architecture, Linda Bird from SNOMED International, Head of Education, and Linda's even waving, Susan Matney, Nurse Informaticist galore from Logica Health, and Rute Martins from MITRE. All right. So I think we would all agree here that the COVID-19 global pandemic has placed a significant pressure on the existing healthcare information technology systems to accurately document and share data. The scale of this pandemic in the modern age of electronic health records had probably yet to be seen. With case reporting, health system capacity management, collaborative research, and supply chain management data has become critical to coordinated response efforts from health systems and public health agencies. This panel is going to focus on the collaborative effort of multiple organizations via the COVID-19 Interoperability Alliance to align the use of standard terminologies, including SNOMED, to improve the data quality and interoperability. I liken this and joke with these guys that I picture this as the Avengers assembling and fighting the good fight. And so we start off with our friend here and our Avengers. And kind of just diving into the various collaborators. We Clinical Architecture, the founding member of the COVID-19 Interoperability Alliance, convening the Alliance really from this need to collaborate and produce publicly accessible resources that were easily downloadable and consumable and were tailored to meet community needs. Our co-founding partner, Logica, whose use case to build the repository of COVID-19 FHIR profiles spurred on that creation in its early days. The folks at MITRE, who are leading the COVID-19 Healthcare Coalition efforts with real-life issues, looking at real-life issues found when trying to author and use value sets to support federated observational research initiatives among some of the major electronic healthcare record systems. Our friends at Regenstrief, who have been rapidly responding to industry need to standardize coding of SARS-CoV-2 related tests and documents. Our fellow terminology management subject matter experts at Apelon, some folks at Care Evolution who provide interoperability solutions and were early contributors to the value set. And our friends at the National Association of Community Healthcare Centers, who are our newest members, official members, who will be undoubtedly bringing some point of care and aggregated reporting use cases to the Alliance. So with that, I'm going to hand it over to Victor Lee.
All right, thank you, Carol, and good morning, good afternoon, or good evening, depending on where you're attending. As Carol said, my name is Victor Lee, and I'm going to talk a little bit about the content aspect of this collaboration across organizations. And in this slide, I've listed a variety of use cases, and beyond just listing them on the slide, I'm not going to go into detail because the other panelists can speak to these use cases in greater detail. But when we talk about collaboration for content for the Alliance, what we're really talking about at its core are terminologies and the creation of these sets. Sets are collections of terms that roll up to a given concept, and they can be used for the use cases that you see on this screen, as well as potentially many other use cases. And again, I'll let my esteemed colleagues talk a little bit more about some of the specifics for how they were consuming the content through the Interoperability Alliance. But digging a little bit more into the value set content, as Carol mentioned, as one of the founders of the Alliance, we saw an opportunity to basically give back to the community in the form of value sets related to COVID-19, and not just specifically COVID-19 and SARS-CoV-2 labs, but really kind of the entire spectrum of content that could be related to COVID. So when people talk about needing to understand comorbidities or complications, as well as that kind of span a little bit outside of things directly related to SARS-CoV-2 or COVID-19. These are all within the scope of what the Alliance is stewarding and curating through its value set offering. We actually started by taking a stab at what we thought would be useful value sets to create. So we looked at things like case report forms from the CDC and the World Health Organization. And we also took specific requests from the community. So basically, this is a set of value sets that are driven by community needs. The terminology bindings address a variety of code systems. Obviously, SNOMED CT is an important part of the offering, but given that some of us live and work in the United States, the codes are recommended by the core data for interoperability, also known as USCDI, are an integral part of our offering. But we really are not restricting ourselves to US-based terminologies. We're really interested in understanding what kinds of terminology bindings to these value sets the community is asking of us. So please, if you haven't already looked at the value sets, and if you have particular needs, just contact us and we're happy to talk about how we can meet your needs. We've also, because COVID-19 and SARS-CoV-2 and all things related to the pandemic are in rapid evolution, many organizations have released pre-release terms. So SNOMED and LOINC and RxNorm and many others have had to basically act quickly and put out some pre-release terms that haven't, some of them now have eventually made it into the standard releases, but we've included pre-release terms in the Alliance, so you might find those floating around there. And of course, part of any value set definition includes the explicit definition of inclusion and exclusion criteria, which we can talk about more if there's interest. And the Alliance has also taken on the work of doing updates and maintenance on a periodic basis. Really are kind of updating the value sets in real time as standard terminologies get updated. And I'll talk a little bit more about where you can access these value sets, but contribution that we've made to the Value Set Authority Center, which is also periodically updated, although not as close to real time. But we'll talk a little bit more about those in the coming slides. So this is okay. So on this slide, this is a snapshot of our COVID-19 Interoperability Alliance website, and you can see the link down at the bottom. So if you haven't visited, this is basically the information that you need to get there, covid19ia.org. And I'll talk a little bit about some of the features on this website. And so let me advance to the next slide. And so what we're looking at here is the workshop, and this is where some of the collaboration happens. Now, of course, we have weekly meetings, and so anyone is invited to attend. If you would like to join a weekly meeting, let us know, and we're happy to add you to the list. But also asynchronously, we have a website, which we call the workshop portion of the Interoperability Alliance. And this does require that you get a free account. Just let us know, and we'll give you the login credentials so that you can log in and see what the value sets look like in real time. You can see kind of along the left side, there's a navigation menu where you can navigate to, SNOMED and other standard terminologies and explore value sets and their membership and other properties. And there's also an opportunity where if you want to make a suggestion for an additional value set, or if you have questions around the members of a particular value set, whether you think something is missing and should be added, or if something is maybe too broad in scope, there are opportunities to submit comments, and Clinical Architecture and the Alliance will have access to those comments and can respond to those. So the workshop is one place where that sort of community collaboration can happen. But as I mentioned, we have weekly meetings as well where we can discuss and debate these issues and how people. Now, unlike the workshop, this is a screenshot of the downloads page of the Alliance website. And you do not need a login to access the download page. You don't even need to tell us who you are. You can come straight here and browse from our offerings. This screenshot was taken a few weeks ago, but obviously if you visit the website, you'll see the current offering. And you can expand by clicking the little plus signs to get a description, and you can directly download an Excel file that has the entire contents of each of the value sets contained within the code systems listed here. There's also a combination file so that if you wanted to get some common combinations of ICD-10-CM and PCS, LOINC, RX norm, et cetera, SNOMED obviously, there is a combined file as well. And again, you don't need a login to access that site. And then taking a second to load. Okay, and this is a screenshot of the Value Set Authority Center, also known as VSAC. And so all of the contents that we've made publicly available on the Interoperability Alliance website, we have also contributed to the Value Set Authority Center. And there are some aspects of VSAC that do not require a login. Many aspects of VSAC do require that you have a free login. So the Interoperability Alliance is one of those. We had so much content that it was we didn't meet the criteria to make it available without a login. So if you don't already have a login, you can request one for free. And if you need help navigating to the COVID-19 Interoperability Alliance value sets, there's over 600 of them. Just let us know and we can help you access them. And the link down. And so in closing, we've really enjoyed the collaboration from not just the official collaborators listed on the website, but there have been many people who have contributed in one way, shape, or form to our collective knowledge of value sets and the use cases that people want to use these value sets for. So we're greatly appreciative of our collaborators, including all the other panelists on this call. And if you've downloaded value sets, we would very much love to hear your feedback about what we could do differently or better. And then if you haven't been a collaborator or a consumer of the value sets, we'd really love to hear from you and check out our website and learn more. Because what we really want to do is not just think narrowly about COVID-19. One day this pandemic will end. But getting your feedback about where we could take future efforts beyond COVID-19. There will be other pandemics. There are many other notifiable conditions. We'd love to hear from the public and understand how we can better meet your needs. So you've all probably heard the saying that we should never allow a crisis to go to waste. So hopefully we've done our part in taking advantage of this unfortunate situation and doing a little bit of good and giving back to the community. And that's all I had.
Thanks, Victor. Hi, everyone. I'm Linda Bird. I'm the Head of Education and Product Support at SNOMED International, and I'm here to tell you about SNOMED International's involvement in the COVID-19 Interoperability Alliance. First of all, here's a timeline of SNOMED International's response to COVID-19. On the 31st of January this year, just one day after the WHO declared the coronavirus outbreak a public health emergency of international concern, SNOMED International published its January 2020 release, and it included a broad range of COVID-19 concepts across at least 7 hierarchies. Then in February, the WHO named the disease COVID-19, and the new virus was named Severe Acute Respiratory Syndrome Coronavirus 2. So on the 9th of March, SNOMED International published its first ever interim release to include these updated descriptions on the COVID-19 concepts. And then 2 days later, the WHO declared COVID-19 a global pandemic. As you remember, it all happened very quickly. Then at the start of April, the members of SNOMED International met to discuss the challenges they were all facing with respect to the pandemic. And during that discussion, our members suggested that they would really like to share their COVID-19 data reporting requirements, to work together and to learn from each other as to how best to use SNOMED CT to manage their COVID-19 related data. So over the next few weeks, SNOMED International consolidated the contributions and feedback from our members, and we drafted the COVID-19 data guide. Around this time, SNOMED International also joined the COVID-19 Interoperability Alliance and started working with the Alliance to harmonize our SNOMED subsets with those being used within the Alliance. And then in July, SNOMED International published a range of additional COVID-19 concepts that had been requested by our members. And in August, version 1 of the COVID-19 guide was completed. And in September, the key COVID-19 content from SNOMED was published in our global patient set for free use in all countries. So here are some examples of the type of COVID-19 content that's been added to SNOMED CT this year. For example, we've added the COVID-19 disorder itself, as well as asymptomatic COVID-19, and secondary conditions like myocarditis due to COVID-19. We have findings from laboratory tests, such as COVID-19 detected and not detected, or not detected in a pooled specimen, and other findings like at increased risk of exposure to COVID-19. We also have observable entities such as detection of COVID-19, measurement of COVID-19 antibodies or antigens, and COVID-19 ribonucleic acid assay. We have the SARS-CoV-2 virus organism, new procedures such as COVID-19 vaccination, events like exposure to SARS-CoV-2, substance such as antibody, antigen, and the ribonucleic acid of COVID-19. We have situations such as suspected COVID-19 or history of COVID-19 or COVID-19 excluded. And we also have new specimen types that are used in the testing of COVID-19, like the mid-turbinate nasal swab and the oropharyngeal swab. And there are many other new concepts as well. As I mentioned earlier, SNOMED International has worked with our members to collaboratively develop the guide to COVID-19 data coding using SNOMED CT. This guide demonstrates how SNOMED CT can be used as a common language for recording, sharing, and analyzing COVID-19 related data. It does this by providing a set of example SNOMED subsets for coding a range of data elements relevant to COVID-19. And these example subsets can then be adapted to meet specific local requirements. You can find the COVID-19 Data Coding Guide at snomed.org/CV19. Here are the chapters in the guide. The main section contains the example subsets, and then the next section describes the maps from SNOMED CT to ICD-10. Appendix A then allows you to download the subsets in 2 alternative formats, and Appendix B provides some example national extension content. So here are some of the data elements for which the guide provides SNOMED CT subsets. For example, there are subsets for provider and facility details, from the type of healthcare professional to the personal protective equipment. There are quite a few subsets for patient demographic details, from biological sex through to care and support circumstances. There are subsets for clinical assessment, including symptoms, measurements, secondary conditions and complications, diagnoses and risk factors. There are subsets for tests and investigations, from specimens through to laboratory test results. And there are subsets for prevention, treatment, and education. So, as a member of the COVID-19 Interoperability Alliance, we went through a process of subset harmonization. We looked at a range of subsets in our SNOMED COVID guide, including symptoms, comorbidities and risk factors, specimens, laboratory test results, and a few others, and we compared them to the SNOMED subsets developed by other members of the Alliance. We looked at what content was missing from our subsets and also from the other subsets. For example, we picked up that we were initially missing rigor and skin ulcer from our symptom subset. We also looked at cases where the subsets used different levels of abstraction or context. For example, one of the symptom subsets used cough, while another one was using dry cough and productive cough, which are more specific. Similarly, one subset included immune disorder, while another included autoimmune disorder and history of Guillain-Barré syndrome from the situation hierarchy. It became evident that the level of detail and context required by concepts depends on the use case, the scope and context of the data element that the subset was being designed for. The use cases vary from high-level reporting, which tends to use more abstract concepts like cough and immune disorder, through to the more detailed clinical data records, which tend to use the more detailed concepts like dry cough, persistent cough, or Guillain-Barré syndrome. The context, such as history of, is often captured in the health record structures itself. So, for example, rather than explicitly using the concept history of Guillain-Barré syndrome, instead you'll often find Guillain-Barré syndrome itself recorded in a health record from the past or in the medical history section of a new health record. We also had situations where the scope of the subsets were different. For example, SNOMED International included subsets for possible COVID-19 risk factors, such as patients' underlying health conditions, their recent procedures, their current medications, and other findings like their smoking status. So this had a relatively broad scope compared to other subsets used in the Alliance, which focus specifically on just the comorbidities and underlying health conditions. So when using these subsets, it's really important to consider the use case and the scope of the data element to which each subset is bound, and to customize the subsets to meet your specific requirements. SNOMED International subsets tend to include the more abstract concepts used for reporting, and then we provide a second matching subset that includes all the subtypes, which may be needed for detailed clinical data capture. So here's an example of one of the subsets for COVID-19 symptoms. You'll see that it includes concepts like abdominal pain, cough, and dyspnea, through to fever, loss of sense of smell, and wheezing. And as I said, there's a matching subset that includes the concepts plus their subtypes. SNOMED International has also included much of the COVID-19 content in our Global Patient Set, or GPS. The GPS is a set of SNOMED identifiers with their fully specified names, their preferred terms, and their statuses, and it's available for free via an open license. The goal of the GPS is to support health information interoperability across care settings, across organisations, and across national borders. And finally, here are some COVID-19 related links. In particular, the COVID-19 Data Coding Guide can be found at snomed.org/CV19, and there are some other relevant links on this slide. So thanks very much, and I'll pass over to Susan.
Thank you, Linda. It's been a pleasure working with everybody in this group and in the Alliance. I'm going to talk about two things. I'm going to give you a little introduction to Logica, and then talk about the FHIR implementation guide that's a library of profiles that we have created that you can use to message data related to COVID. So Logica is a non-for-profit company, and our mission is to improve health by creating vibrant, open ecosystems of interoperability applications. So we have the Logica sandbox that people use to go in and test their applications. We have a marketplace where you have applications, and we also have FHIR profiles and information models that people use within their applications. So, like I said, it's a 501c3. It was formed in 2014. Our benefactor members are the Veterans Health Administration, Louisiana State University, and Intermountain Healthcare. And I work for Intermountain Healthcare and am in-kind employee to Logica. We have a small budget of about $300,000. We have current members of Cerner, Allscripts, Walters Kluwer. I'm not going to go through the list, but we have academic centers. We have professional societies that we put our content past and that they review for us as we create FHIR profiles and information models. So we are developing an open shared repository of detailed clinical models. They're licensed, but they're free for use for everyone. They're Intermountain models that are converted to CIMI models and FHIR profiles. And we have a CIMI and Logica, which used to be called HSPC repository. The models are reviewed across the specialties that are requesting them. And then there's an environment, developer's environment, and a sandbox. So when the pandemic started, we decided to voluntarily create, we're not paid to do it, a FHIR profile library implementation guide. IG means implementation guide. And so it consists of a library of reusable FHIR profiles, which is different from a normal IG, which is what you would use for an app or across an implementation. This is a library that you can pick and choose from what the profiles are. So it can be used in many situations. It can be used to assist with documentation, and it can be used to assist with analytics. And Rute's going to talk more about analytics as she goes into her section. But the goal is to create consistency of data across COVID-19 implementation guides. And we want to be able to facilitate interoperability and eliminate redundant work. So hopefully you will be able to use these. The Office of the National Coordinator has put our FHIR IG in the Interoperability Standards Advisory as a recommended standard for use for messaging the COVID data. We got data from a lot of sources, which, like Linda said before, sometimes it's hard when you have so many different use cases, because we did have, molecular and atomic concepts coming to us. So the CDC COVID-19, the patient reporting form, the WHO case reporting form. I'm not going to read this whole list, but we had input as far as what the values were in the value sets and what the elements are that we used for the fire within the profiles. This is
Susan,
a list.
pardon the interruption. It looks like, at least on my side, that we're still live on your introductory slide. And I don't know, I think that may be the case for others too. But I don't know if you need to advance with the next button.
I am.
Okay, I apologize. Maybe it's just on my side. Sorry.
So should I go backwards? Let's see where you are now. I'm on the contributors. Are you seeing that now?
So I don't believe
I think you need to take control. I still have control at my end.
Oh, for heck's sake. Okay, we need to stop and start.
I can tell a joke for all of you in the live audience, but we're going to fill here 30 seconds while Susan takes control. I don't think you need to back up on the verbiage, Susan. Maybe just jump ahead to the slides.
I'm not going to back up. I'm just going to go
I know
to
our
the slides.
access to the slides, and
So now you've heard all about Logica,
right,
and what we do, and who we are, and the Fire IG. And thank you, Victor. Appreciate it. And so there's the sources. Here's our contributors. So now I'm in the right slide, and boy, am I glad you told me, because I would have been real embarrassed if I had to talk through all these slides with nobody seeing them. So we've had a lot of contributors to the content within the Fire Implementation Guide. This is the main screen that you really need to see, which has the link to the Fire IG that you can go in and freely download. All of the value sets used within the implementation guide are also in the Value Set Authority Center, so you can go in and find everyone that's associated with the coded elements. This is just an overview of the different kinds of profiles that we have developed. We worked with the CDC to do the exposure and travel history. We did fire condition resources as both present and a condition absent, as well as signs and symptoms as present and absent. And then there's the underlying medical condition, and then all of the lab results. And note that the lab results are encoded with LOINC, and then if they're a coded lab result with positive or negative, that is a SNOMED code. So we reference some profiles that are already used across in the industry. We reference vital signs, patient demographics, smoking status, and we've developed many value sets, and this is just an example set of what we have. So some of the lessons learned, HL7 doesn't have a library of fire profiles, only a library of IGs. And so when we started working with the World Health Organization, they recreated some of the fire profiles that we have in ours because they wanted to be able to version their IG. This is an issue that we're going to take back and have talked to HL7 about, is we would like to have a library of profiles and not just a library of implementation guides. It's hard to develop fire profiles without really good use cases, and implementation is key to interoperability, and collaboration with many, many organizations is difficult and challenging. So with that, I will hand this over to Rute.
Thanks so much, Susan. So my name is Rute Matney. I work for the MITRE Corporation. The MITRE Corporation is a nonprofit organization that works in the public interest, and we operate several federal research and development centers. And as part of this pandemic, really the question we were asking ourselves was, what can we do? And we ended up standing up not alone, obviously, but we're facilitating and moderating a lot of this. The COVID-19 Healthcare Coalition, and it's intended as a private sector-led response to the COVID-19 pandemic. We have over 1,000 members, and our mission really is really simple: to save lives by providing as much as we can real-time learning, information, data-driven approaches to healthcare delivery and to protect populations. We just had an impact report released not too long ago, and you'll see the kinds of areas that we're working in. We're working on supply chain and logistics, where we, for instance, validated some mask decontamination strategies for when the PPE equipment had to be reused, and what was really a good way to decontaminate the masks. We've developed a decision support dashboard to really inform key decision makers at local levels in terms of what they can do and when to reopen, when to start reopening. That was a big question a few months ago, and we tried to put as much data behind this as we could. We also promoted a lot of innovation around testing and contact tracing. And then the portion that I'm going to be focusing here today is really about optimizing COVID-19 treatment and how we could use data to support some of that decision making. So we're really doing large scale analytics for COVID-19 in several therapeutic areas, including the use of convalescent plasma and some research around that. So specifically, we have over 16, I think, working groups. The Optimization of Clinical Therapeutics and Protocols Working Group is the work group that worked most closely with the partners here, the COVID-19 Interoperability Alliance. And you'll see a number of folks who are involved here. You see a lot of big EHR names, as well as EHR analytics and data health analytics companies, clinical architecture, obviously, but other terminology vendors as well, and MITRE. So we came together in early April in trying to see what these organizations could really do together. And it's important to say that everyone who collaborates in the COVID-19 Healthcare Coalition does do pro bono. So this is really a coalition of the willing, and really our goal is to improve and save lives at a national level without any sort of money exchange. So all of this work has really been done, actually just like the COVID-19 Interoperability Alliance, all pro bono. The group came together in early April, and we started looking at what we could do. And what was immediately apparent is that we could start some federated observational studies. We were sitting on a lot of data, probably the most data that had been collected and continues to be collected on COVID-19. And so we wanted to move quickly to design federated observational studies quickly and start working on seeing and comparing results across data partners and refining, continuing the iterating process around that. So we really started very, very simply. We continue to improve and create more and more sophisticated methods, both in terms of study designs, more complex study designs, as well as more sophisticated definitions for cohorts, as well as more complex statistical analyses. And what we've seen is that the partners really value this back and forth and this successive improvement in the process as they were taking the learnings back and kind of catching different things they needed to address on their own systems. And so that was just and continues to be an incredible work that we're facilitating. Here's an example of an actual study we published on our coalition website, and the link is very faint there because it's blue, and so is the background. But if you click through, you'll see the details of this study. We looked at famotidine use in hospitalized COVID-19 patients across 3 different data partners, over 56,000 patients. And what we learned was that famotidine really wasn't making a difference, even though it was touted at one point as a potential treatment for COVID-19. And what we hear is that this data really helped focus on other medications and other research, other medications and other potential treatments. So this is the kind of thing that we're doing. What we are, this is a little bit of the slide of the sausage making. We started really with macro alignment, and we went further and further up those stairs. It's kind of counterintuitive, but there's more detail at the top. So, but we started with really aligning research questions. What were our partners really thinking about, thinking that they could make a difference on? And we quickly found some common areas. And then really trying to align on study design. What kinds of questions are we really asking this data? What populations are we looking at? We moved on to cohorts. For instance, we spent a lot of time in the first few days and maybe weeks discussing how do we define a COVID-19 patient? What is a COVID-19 patient? A COVID-19 positive patient that's hospitalized. And we found that there were several pieces of data that really needed to feed into such a definition. And so we really dug into, well, we can have clinical diagnosis, we can have laboratory tests, and what are the timing constraints around those, and a hospitalization that would confidently put a patient in the COVID-19 hospitalization cohort. So we had all of those discussions, and obviously all of those end up with terminology. What codes do we use to define COVID positivity? What LOINC codes, laboratory tests, do we use to determine COVID-19 positivity, and so on? And that's really where the work with the Interoperability Alliance really started. This is just an example of how we standardize some of the cohorts and data elements. This is just plain a plain web page. It's nothing fancy. What we realized in our work was that we couldn't really over-engineer if we wanted speed, and we really had to use what was already in place if we wanted to get to the data quickly. So we could have used more sophisticated standards that we know are out there to design some of this, really document some of these definitions, but we opted to go the simple route and really produce data more quickly. And in terms of the work we've done with the Interoperability Alliance, and I'm going to speak a little bit more about our process and how we consumed and iterated with the Alliance on these value sets. I really wanted to spend a moment here on terminology challenges in what we've been doing in retrospective observational studies. And most of this is not new. It's true for every observational study out there. We're not starting with a blank slate. The data is already there. It's already collected. It's there in its diverse glory. And certainly there are unique data models out there for each of one of these partners. In fact, we were lucky that we were working with a handful of partners and not each health system in the United States, for instance. Obviously, there are challenges that the partners were already tackling on their own. And then obviously in terms of trying to get those cohorts right, we really need to think about not just getting every single last patient that we think has COVID-19, but also who are we bringing into that cohort that may not have COVID-19. And so there's really a balance between sensitivity and specificity. The example that I'm providing on this slide here was actually a big point of contention around pre-existing heart failure, and specifically with ICD-10 in this case, because it appears that a lot of coders use unspecified heart failure, an ICD-10 code to code for chronic heart failure, really. And so we had to segregate codes, if you will, between chronic, unspecified, acute, and use them with different time frames as a building block approach to really get those chronic heart failure patients without pulling in patients who may have heart failure as a complication of COVID or a COVID treatment. And so these really get into really fine-grained discussions that turn clinical very quickly. And I'll address a little bit more about how we really have solved some of these problems in a minute here. Another example of an issue we had is just plain English, right? As we try to communicate, we think we're being so clear on what we're communicating. And when you read chronic kidney disease stage 5 or ESRD, is it a value set that includes stage 5 and ESRD, or only codes that include, that are mixed codes that point to stage 5 or ESRD in a single code? So those are some of the things that we actually came across that we had to really solve. In terms of timing, I've already given you the example of heart failure, but another really important consideration, especially as we think about comorbidities, this is actually by and large the category of data elements that we've spent more time on, is really consideration of historical codes. A lot of what we're looking for may have been documented 2-3 years ago, and so historical codes become important, not just the live bleeding edge editions of current terminology. And the example of really heart failure really provides a good example of the interplay between what the value set content is and how you can use it to build a query that's clinically meaningful with different timeframes, perhaps, to go along with those. So the reason why we ended up leveraging COVID-19 Interoperability Alliance value sets, they were very attractive for several reasons. They were openly available. There's a really strong focus on standards, and the centralized content maintenance was really important because we really wanted to focus on the study design. We wanted to focus on the pieces of coordinating our partners in really getting to that finish line of getting some results. It was immensely helpful to have a third group that we knew had broad and deep terminology expertise that acted as a single source of truth for terminology content. The reality is that a lot of our data partners were already going down the path of creating their own value sets, their own definitions, and we were able, for the most part, to really bring them together, aligning on these value sets. And vice versa, we were able to actually improve the Alliance value sets with their feedback as well. And then because the content is developed to be there's a bit of a building block approach, it really helped us to get some Legos and build our buildings with those. And so we were able to reuse some content and just create some logic around it instead of creating yet a new value set for something that already existed in, say, 2 separate value sets. It's been incredible to work with this group in terms of really developing and driving this content home so quickly and with as many iterations as needed. The speed is really, really appreciated. And again, the centralized content management and maintenance is really priceless, given that everyone's so busy trying to already do their work. It's really helpful to have someone who's focusing on this lane. So here's a little bit about our process and how we worked with the COVID-19 Interoperability Alliance to develop studies. Really, the development came through a use case lens, and sometimes the Alliance content was already there. So we really were triangulating a little bit of a clinical knowledge and expertise, what we wanted to include in our cohorts, with really strong knowledge about the data that really existed and how we could use it, along with the expertise lens. And bringing these three together really made for really strong value set definitions, I think. We worked with both our partners, which included not just data folks, but also lots of clinicians, lots of MDs, terminology partners, and really doing a clinical review and using live data to test these value sets, often side by side. And it was really interesting to see that, oh, we missed this one code, so we really should revive this because we get an additional 2,000-3,000 patients with a comorbidity. So testing against real live data really makes a lot of difference both for that sensitivity as well as for the specificity component. And finally, obviously all of this results in needing to revise some value sets, needing to do some fine tuning and tweaking here and there. And the collaboration and the speed at which this has happened really has been amazing. Finally, you know, we've been working on some therapeutic studies, but the questions around COVID-19 keep expanding. What you're seeing here is an example of a really simple reinfection tracker that we've put together with our partners. And we're really building on the robust foundational data definitions that we've come to with this group and with the Interoperability Alliance. And we are answering different questions. So what you're seeing here is actually how many patients are testing positive in their PCR for COVID-19 more than once, and how long between those, the first and the last test. And fortunately, what we're seeing is that most patients are testing positive more than once. 28, 35, 42 days is really the rightmost significant bar here. So we're really not seeing evidence of infection at a population level. And this is from data from, I think, every single partner contributed to this data set with the coalition. So none of this would have been possible without the unwavering work and passion that everyone has brought to the table here. And this is a list. I'm probably missing someone, but this has been a great group to work with within the COVID-19 Interoperability Alliance and the COVID-19 Healthcare Coalition. And it's just been fantastic to see what we can do and so quickly together if we're just really invested in it. And it's been a great, great experience. Back to you, Carol.
I think so. Monica, you might have some instructions here as we close out the recorded portion. If not, I think at this point we would move on to the live questions.
Thanks, Carol. I do. Thanks, everybody. That was a wonderful presentation. Great work by everybody. Carol, Linda, Rute, Susan, and Victor. Thank you. Can I ask everyone to give us a few minutes while we switch over from our recorded content so that your questions that you've been submitting live can be addressed? And just a reminder that this session will be available on the event platform for the next 3 months. Well, I just wanted to say thanks to the team there. That was a great presentation, lots of information and great endeavor by everybody. Thank you so much. I'm going to be hosting the question and answer session. Just want to point out that we have Rory Davidson taking the place of Linda Bird for us today because Linda is in the Southern Hemisphere, not able to join us at the moment. I don't see any questions in the window at the moment. Does anyone have any questions they would like to ask of the panel? Well, I guess you just covered everything so well. It seems as if there are no questions coming along. Anything anyone would like to add or say? I mean, since the presentation was a couple of weeks ago, anything, information that you think you maybe would like to share that wasn't shared before?
One thing I neglected to put 3M on the slides, and they have shared their value sets that they've been creating all along with us, and the Alliance has been reviewing them. So I appreciate the work that they have done.
So in other words, they'll be adding those to the list of...
No, we just compare them to ours.
Okay. That's great. Good to know. Okay, well, if no other comments and no other questions, I'd just like to say once again, oh, Rory's got
Linda, do you have a question?
I was going to say, I was being a bit cheeky, as even though I'm Linda, I actually do have a question for the panel. I'm curious to see where you think this goes as the pandemic continues, and the work that you expect the group will do, and that you kind of want input from the community going forward. I'm interested in everybody's views on that one. Who's going to go first?
Well, this is Susan. I'll go first, because coming from the fire perspective, and then maybe we can drill down to terminology with Victor and others. We're starting to see how public health diseases can be structured and what's needed for those. You know, the signs and symptoms, the underlying medical conditions, the labs. We'll have a structure if we have, you know, for other public health conditions that we can use moving forward.
And I would pile on to that you know, that has a very clear application in syndromic surveillance, for instance, right, which is something that has remained elusive in terms of automated mechanisms to complete. And we're starting to explore that with partners.
So as it happens, we do have a question actually from Christopher Gray. The question is, how do we expand this alliance across the globe?
It's already international, right?
Well, just reach out, Christopher. Anybody can contact us. Just look at the slides and contact us, because we're working with the World Health Organization and the fire profiles they're creating for their case reporting. So reach out to us.
Yeah, and I guess inherently it's international in our partnership with SNOMED and the intended use of guidelines that Linda is leading. And we've also recently been contacted by some folks in Canada, and we'll be looking to perhaps expand the value sets to include the Canadian specific content, you know, including the Canadian National Extension of SNOMED. And so, yeah, we welcome the contributions. I guess looking forward, you know, we're also looking to take community feedback and do things like expand or reuse content around things like social determinants of health. And, you know, Susan and the folks at Logica in turn would look to perhaps create additional profiles that included some of that content.
Yeah, and I'll just say that we had some discussions early on around what kind of code systems we would want to bind value sets to. We had early discussions around, you know, for example, should we support ICD-9, because there's still, I think, some countries that are still on ICD-9. I think Italy might be one of them. I could be wrong. But we decided to focus on what the community was asking of us. But I think, as many of us have alluded to during our presentations, this is really a community, a globally driven event. So if you have needs, if you'd like to make a request or to collaborate with the Interoperability Alliance, we'd love to hear from you.
Terrific. Thanks, Victor. Well, I think if no more questions, that concludes today's session. And once again, a big thank you to all our people presenting, and also thank you to everyone for attending, for your interest. And I hope you've learned something and can find a way to put this content to use. Thank you.